Happy Friday. I can't hear you, John. I still cannot hear you, John. Maybe you can send me another link.
Can you hear me now?
I can hear you now. Perfect.
It's my fault, not your fault. I apologize. I had my mic turned off and I hadn't realized it.
Yeah, blame me.
Yeah,
Sure.
Okay, now that was my fault. So sorry.
Yeah, well, 20 lashes with a wet noodle.
So I was just telling them the story about my disc herniation. And the bottom line is I've had much less back pain ever since that event occurred. But it just shows how intense the inflammatory reaction can be if you have an acute herniation of nuclear components, and you really get an inflammatory reaction that can go up and down the spine. So I can tell you that there are situations with younger people with acute herniations where epidural injections are a miracle. But I'll also tell you that 98% of epidural injections are a waste of money for people. Don't have the acute. John, could you mute your mic this time?
Yeah, I hear you.
Okay. Yeah, but we can hear you rattling around. If you could just kind of mute your mic and then just turn it on when you want to talk, that'd be great.
Oh.
Or okay. Uh, uh, so there's a time and place for it, but the vast majority of people who have chronic, long-standing degenerative disc disease, epidural injections are probably equivalent to placebo effects. Okay, so that's the nucleus pulposus. Then you have the annulus fibrosus around it, Sharpie's fibers at the edges, and then on the above and below it you have cartilaginous endplates. So this is the anatomy of the disc. This is what the kind of can look like in most people. This is a histologic section for the nucleus pulposus, and here are the annular fibers on either side, the annulus fibrosis, and then these are cartilaginous endplates on either side. So the pathophysiology of degenerative disc disease. And there are probably several things that happen concurrently to produce degenerative disc disease. One of them, you can get end plate injuries from increased pressure, and the increased pressure on the disc, the nucleus pulposus can absorb that, but it still increases the pressure, and you can get end plate fractures on the disc. Once you get those fractures, it can damage a little bit of the nutrient blood supply here. You can get decreased glucose and oxygen, decreased cell metabolism, loss of at least a lot of these other things, which can then lead to what we'll talk about motor changes. So you're all familiar with the term motor changes. They're actually described by Mike's fellow at that particular time, and I'll talk about that when we get to motor changes. The first thing you see in a type 1 is really edema pattern within the end plate. That's probably the end plate injury. Then what happens as you go along, you'll develop replacement of the normal marrow by fat. That's a typical bone response to injury where you affect the nutrient supply to the hematopoietic marrow. Hematopoietic marrow can't function well when you don't have a proper nutrient supply, so you get fat replacement because fat cells do very much better in a O2 and a glucose depleted region. And then eventually you get eburnation and sclerosis of the bone as really the end stage. So that's motives 1, 2, and 3, and they come in that progression. So that's one thing where the primary injury is actually to the end plates. But also with trauma, you can get disruption of the annular fibers. You can start getting herniation of the nucleus pulposus into the annular fibers. You start getting volume loss, and you get dehydration of the nucleus pulposus. Then we go through that same process of loss of glucosaminoglycans and aggregans, and that leads to a stiff disc. A stiff disc can no longer absorb the impacts, and twisting that puts more pressure on the end plates and the trabecular bone, which leads to trabecular bone injury, and you get a circular process leading to more and more degenerative disease. And that's
the problem is time. it takes a tremendous amount of time to get a nutrient, proteoglycan or whatever kind of nutrient that's going to go to the disc. And it takes too damn long. And then so the recovery of a disc that's been injured or whatever has happened, it's virtually impossible to renourish. And I think that's one of the problems. But to go back a little bit, in terms of placebo effect, many medications and that we prescribe are placebos. We don't know that, but they are. I have had patients where I examined the patient while they were having spasms, and they said they've had pain for 2 years off and on when they play golf, etc. And during the examination, I press on the spine, posterior spinous process, and one fellow, an old friend of mine, all of a sudden he says, "Oh my God, my pain is all gone." and he was complaining of pain to me every time I saw him.
Magic.
So I say placebo is kind of interesting. Now, is that a placebo or what is it? I'm not able to tell you.
Okay, great. So as John was saying, the nutrients for the nucleus pulposus diffuse in from the vascular supply, which is around the periphery of the disc. And actually, if you measure it, you can see that around the periphery, you can have the glucose and oxygen near the levels in the serum, but very rapidly as you go into the disc, you see that the nutrients drop off and the lactic acid goes up. So the central part of the disc has a much higher lactic acid, which means anaerobic metabolism, which we can see in really both of these graphs. And then if you actually do a study where you see the amount of time it takes for nutrients to diffuse into the center of the disc, just like John was saying, it takes close to 12 hours before you can actually get nutrients to diffuse into the central part of the disc. So as John was saying, getting...
It depends on the nutrient.
Yep.
Some of the nutrients that are glycoproteins take a long, long time.
So here we can see there are different kinds of nutrients that they were measuring in this particular study from this particular paper.
What is normal?
This is normal. Well, they think it's normal. Oh, no, these are different biochemical agents.
Okay, so normal is like a control or something?
Oh, I'm sorry. Wait a second. So I think this is glucose that they were looking at. I'd have to go back and see. What I was really trying to show here is the fact that it takes a long time for it to diffuse in. Mm-hmm. So, these were different diffusions, and I forgot what these are. What I really want to put out is just that it takes a long time for nutrients, and I think they were looking at glucose here in this particular case. And as you know, you require all these for active cells to live and metabolize.
A night of sleep probably will do it.
Yeah. And then, so then what happens is if you have injury to the end plates, this is even delayed more because the interface between the blood supply and the margins of the disc become interrupted. And if you have a lot of eburnation, the bone thickening becomes much thicker. You have fewer blood vessels, and therefore it even takes much more time for any nutrients to diffuse in because you don't have the same interface between the vessels and the disc. So this is what's thought to lead to the degenerative disc disease. And there are two different studies that have looked at different ways to grade it. This is one from the spine from 1990. So this would be a normal disc where you see normal nucleus pulposus is bright on T2 weighted images. The annular fibers is dark. early degenerative changes, you start seeing a cleft within the disc here, kind of the Oreo cookie, reverse Oreo cookie kind of sign. And then you get more loss of signal, more irregularities of the surface, and finally collapse. Different disease. I actually find, I don't use this kind of grading system. I find that it's not very precise, and it's difficult to determine a lot of these intermittent gradings. And unless you're doing some sort of a study, it doesn't really affect management at all. But just be aware that people have looked at that. And then disc disease has been classified by the North American Spine Society. And so what they like to say is disc disease, you can classify it based upon the nuclear signal intensity, whether you have herniations, and herniation is any extent of nuclear material beyond where it normally should be. But in particular, when we look at imaging, we're really only looking at the extension of nuclear material beyond the edges, the peripheral margins of the disc. So you can actually have internal herniations into the annular fibers that we don't reliably pick up with MR. We only pick it up when it goes to the peripheral margins. And these are divided into protrusions and extrusions. You can also have a diffuse bulge of the disc, but a diffuse bulge that is extended beyond the normal confines of the vertebral body for more than 180 degrees circumference is considered straight degenerative disease and not considered a protrusion or an extrusion. And then if it's focal, you look at location, size, whether you have nerve compression or any other changes. This actually is another system that's very similar to the previous one. The first one was published in 1990. This in 2001. This is from the group in Europe. Very similar, but you're basically looking at signal intensity within the nucleus pulposus. So what is this significance of disc signal, and how does it correlate with discography, which we used to use? This was a study in pain back in 2008. They found that a positive discogram is uncommon in discs with normal signal. Less than 15% of normal discs that they did a discogram on created pain. Positive discography is common if you have moderate signal loss within the disc, and it's very common if you have severe signal loss. But if you have severe signal loss and compression of the disc, that's not really surgical. So the ones that they were concerned about were really in this middle category. But then when we talk about discography, it's something that's really not used very much anymore. In the years that I've been doing this stuff, discography has come and gone multiple times. Now it's often used by people to try to justify doing surgery when the rest of the findings don't justify surgery. But for reasons that we're going to talk about as we go forward, whereas insurance companies in the past would cover surgery if there was a positive discogram, most of them no longer use that criteria to determine whether surgery is indicated.
What's interesting is one of the best neurosurgeons in Santa Monica, who's deceased now, and he worked with me and for me for a while when he retired. He gave up discography, which he used to do himself 40 years ago.
Yeah. Okay.
There was no way he could correlate that with surgery. So he gave it up. Okay. And he was kind of laughing at the folks rediscovering America.
Yeah, right. So this paper came out in 2008, and they recommended doing discography for those discs that had kind of intermediate degenerative changes where you didn't have a completely collapsed disc, you still had some signal within the nucleus pulposus, but it wasn't entirely normal. Then in 2009, Karagi, a neurosurgeon at Stanford, published this paper, which finally changed the world. They did 200 patients, 200 individuals with no history of back pain. They did discography on this. How they arranged to do that, I don't know. I'm sorry, 50 patients with 52 matched controls. Okay, so there were patients and 52 were asymptomatic individuals. Sorry about that. They did both MRI and discography in 1997. And they followed them for 10 years and then did a repeat MRI. And what they found is at the level where they did the discography, there was a clinically significant increase in degenerative changes in those who had discography that did not occur in patients who did not have discography, as well as decreased height and signal loss within that disc. And they also found a significant number of new disc herniations weren't there on the first MR on the side of the puncture of the discogram. And you typically don't get herniations on the side, though you can. But these were herniations right at the puncture site. So he said that there was really a need to get away from discography because his study showed that discography actually damages the disc. And discography markedly decreased after this paper was published, and it actually won a bunch of awards. But recently, in some medical legal cases I've seen here in Southern California, surgeons have tried to get reimbursement for surgery based upon the fact that they've done a recent discogram, and they thought that was an indication for surgery, though the insurance companies denied it. But they did the surgery and went to court to collect on it. So there still are some people who try to use discography to justify doing surgery.
So what is a positive discogram?
Okay, positive discogram. And that's something that the question is, what is a positive discogram? And that's something that has been debated a lot. So typically the way you do a discogram is you prep the patient, put them under fluoroscopy. You stick a needle from the side into usually 3 levels of discs. You inject contrast to a certain pressure. If you induce pain, the patient's same pain at that level, that's a positive discogram. People also look to see whether the contrast extends through a tear in the annulus. And a lot of people will do a post-discogram CT to look for that. But a lot of studies have shown that extravasation of contrast has no correlation with patient symptoms. But the presumption is if you increase the pressure and reproduce the patient's pain, that means the pain must be coming from that disc.
That sounds barbaric.
But as John said, there's a lot of debate about whether that's really true. And there are no good studies to actually show that there's long-term improvement of patients based upon between patients in a control group who then have surgery at that level. So without that, there's really, I think you just have to say there's no good data to say that basing surgery on a positive discogram actually leads to better outcomes. John, you were going to say something?
I actually think it's a bad idea to even do a discogram for more reasons than that. It's just looking for trouble, probably. The thing is, you have the meningeal nerve, which gives off the intervertebral nerve, and then the fibers of these nerves go up and down the spine and are interconnected between 2 or 3 discs. So the patient has pain, but how do you know whether it's a pain from a disc above or the disc below or the disc where there is a lesion? It's really hard to tell. And I think that fellow at Stanford should be applauded. But then Stanford, I don't know if you guys know it, is the second top university in the world.
Yeah, I've never heard of them.
Good shot, John.
So generally with MR now is what we're going to look at is the morphology of the disc. And so that's what's gotten a lot of interest. And we're going to talk about protrusion, extrusion primarily. So this actually comes from the SNR website from a few years ago. This would be what the normal disc and nucleus pulposus looks like. And notice that there is a little bit of bulging of the normal disc. There are many radiologists, you'll see a lot of reports when you go out into practice where people will call this disc herniations, especially if they work with the medical legal world where they're trying to justify doing surgery, which is extremely common. This
plaintiff's legal work.
Right, exactly. And then here we can see that this would be an annular tear in this location where the nuclear material goes through here. By the way, we'll talk about annular tears in a minute. Most of what we call annular tears are probably not nuclear material, but some of them are. And then a disc herniation is where, by imaging criteria, is where the nucleus pulposus extends beyond the margins of the disc itself. Now, this is talking about nucleus pulposus. Now, what's an annular tear or annular fissure? Here we can see it's a focal area of high intensity on the T2 weighted images in the region that should be annulus. And notice this is much brighter than the nucleus because the nucleus has become dehydrated here. So in orthopedic textbook, like John's going to tell us in a minute, these are typically called high intensity zones. And the reason they call them high intensity zones is that they don't want to use the tear term. Because as I'll show in a minute, the vast majority of these are chronic, stable, degenerative lesions in the annulus. They're not due to acute tears, and they're not due to a collection of a nucleus pulposus, because notice the nucleus pulposus is a completely different signal intensity here in the vast majority of these patients with degenerative lesions. So this is called an annular tear or annular fissure or a high intensity zone.
Is that the term you use in reports?
Okay, so
I like the word fissure because that doesn't lead to surgery. You use the word tear, and surgery comes to these folks' mind. So I like the word fissure to keep surgeons away from using that knife.
don't you say Campbell's recommends high intensity zone?
No,
But you said
well, yeah, but I've always liked Fissure, John.
that's it.
HIZ is being used, and nothing wrong with it. But you and I have used Fissure in our reports many times.
So
I don't think we use HIZ in the reports.
Yeah, so I don't say annular tear. I used to say annular fissure. Now I generally use the high intensity zone, but because I think it's an area of high intensity zone, the vast majority of these are not due to an acute injury, and there's no evidence. There is one report out of Australia, I believe, that if you have a high intensity zone in association with a focal disc protrusion, that may be associated with symptoms. But if you look through their paper, there is no accurate way to determine whether any lesion in the spine is a cause of symptoms. So I really hesitate to believe that particular article. So I don't think these are associated with symptoms. And I certainly, there is no evidence that I know of that operating on these lesions improves outcomes, which is really what you'd want to know. And that's usually what people are talking about. They're trying to justify surgery.
So
here it is in the axial plane. Yes.
The outcome is a bank account.
Okay.
Do you say there is like this protrusion here, or you just say there is like high intensity zone?
Okay. So in this particular case, I would say that there is a focal protrusion, and we'll go through this in a minute. In the foraminal zone, containing a focal high intensity zone, or annular fissure, if you want. I just don't want to call it a tear. So the North American Spine Society defines high signal within the annulus, and you want people to use the term high intensity zone, because they also believe that this is not an indication for surgery. This may be due to vascular tissue, granulation tissue, or an annular fissure. The vast majority, I think these are due to granulation tissue. The term annular tear is considered non-standard terminology. So this is even the Spine Society says you should not use annular tear. High intensity zone does not imply trauma or a painful disc. So this comes from the Spine Journal, and but what you'll find is there are a group of radiologists associated with the plaintiff sides who like to call these tears, and there are some surgeons that think these are painful and believe that they should be an indication for surgery, but that's not what is generally considered correct. So here's a case. This is on 3904. We can see that there's a little bit of desiccation of the annulus at this particular level. Not really a significant protrusion in that level. So now if we followed over time, though, 3 years later, what we see, now there's a high intensity zone here. There's decrease in the height. There's more desiccation of this disc with respect to the other discs. And we can see this high intensity zone / annular fissure, whatever you really want to call it, in that particular location there. So this was a new annular fissure. So they can develop like this. The vast majority that I've seen, and I've seen many of these, where we've had follow-up MR scans over many years, is that once they develop, they become very stable and they don't change. What I want to imply here is this is not an indication that you have recent trauma, because many people want to imply that because you have high signal here, it's edema within the annulus, and therefore it's an indication of recent trauma, and that's wrong. It may not exclude recent trauma, but it's not an indication of it. So there we can see that here's a patient who's evaluated for central stenosis. We can see an annular fissure here at 5. If you go back in time, the patient actually had a significant focal protrusion before, which was not operated on. And as they went on to, we'll talk about the natural progression of a focal acute protrusion. The bottom line is that over about 9 months, if it's a focal protrusion, they almost all resorb. And when they resorb, you can be left with an annular fissure. So I really believe, looking at a lot of these cases where we've had a lot of follow-up over time, that most annular fissures are actually scars from prior protrusions.
Why does it stay bright over time like a bruise?
Because it's stable granulation tissue. It's basically a scar. It's the way you get scar formation in the annulus. And it seems to be...
Well, it changes with time as you age, and then becomes scar tissue, of a fibrotic tissue rather than being granulation tissue, which is a little different from scar tissue.
Thank you.
Well, don't you think, John?
Sure, that's fine. Yep. So here's a 29-year-old Major League Baseball pitcher who had back pain for 1 week. Then severe pain developed, extending to the SI joint after the first inning pitching in a game. So let's see. What do you see here?
Okay, I see. I'm not sure what level is that. Is it L2, L3 probably? Yeah, maybe. Okay, so there is this protrusion, and it seems that we have tear of the annular.
Okay, so it's funny, I haven't described how you describe these yet, but I will. So what we can see is that there is some nuclear material extending out, being contained by the posterior longitudinal ligament, descending a little bit up and down the spaces there. If we go to the axial images, we can see it's right here in the lateral recess, and probably extending into the foraminal zone, where it can compress discs. And we can see also here that there's some thickening of the adjacent soft tissues here. Now that could be annular, that could be nucleus pulposus, which is extended out. But as I said, once you get nucleus pulposus outside of where it's supposed to be, you can get inflammatory changes. And they actually went in to operate on this, and there was an annular, acute annular protrusion and some inflammatory changes around it. Here's another case where we can see...
John?
Yes.
If it hasn't gone torn through the posterior ligament, it probably it is not as painful as if it had.
Yeah.
Where I think the ligament, if you tear that may be due to trauma, but most of these are not traumatic.
Right.
Most people it's a degenerative process from the age of 14.
Yeah. And then here you can see there's a patient who you can see stable annular fissures, annular high intensity zones over, this is almost over 2 years. And we've had some now where we've followed for over 10 years where these high intensity zones stay quite stable. So it's really not a good indication that you've had recent acute injury, as some people like to state. And here are just the axial images showing some minor morphologic changes over time. Here's a 50-year-old with back pain, and here we can see a little high intensity zone extending into the annular fibers here, fibers, 1020. This is a little over a year later. These can get better, as we can see here. And then we can see instability at the 4 or 5 level. So they can. Okay, here's a 49-year-old attorney with back pain after a motor accident. What do you think here?
So I see a little high intensity zone, one of the higher lumbar vertebral body levels.
So you can see it right there. That's on 1/10/2003. This is now many years later.
Looks like there's a little part now on the left, or the left.
Go back here. That's what we had before.
Yeah.
We see it really at the 2-3 level. And now if we go to...
there's another level, yeah.
We can actually see there's now another level and a little bit of extension here.
Mm-hmm.
But again, these are really chronic. This is over many years, relatively stable. And here's further follow-up. And in this particular, this is a
different guy.
This is different. So this
49.
is this person.
Yeah.
So yeah. Now, going forward here, he actually, we can see a little bit of progression of the high intensity zone or annular fissure, and then now we can actually see in that same area he actually has an extruded disc. So it probably is an area of weakening, but the high intensity zone itself really is only an indication that you have some degenerative disease and prior injury to the annular fibers. Probably maybe a weakened area, and you can get an extruded disc through that area of weakening.
And that should resorb.
John said, we'll talk about it in a minute, these almost all resorb on their own. And as opposed to 15 years ago when this would be considered an absolute indication for surgery, as we'll talk about next time, these actually, this is what you want to have because 100% of these get better. Whereas most of the other stuff we'll talk about that cause pain don't get better. And you don't need surgery for it. Though there are some people who have excruciating pain with these extrusions that you can't control well. And if you do operate on these, that will get better right away. But at 1 year, as we'll see later, there is no difference in the outcome. So you try to get by these and let them resorb on their own because these are not fibrous components. This is nuclear components. But if it's if you can't control the pain, then you may have to have surgery for pain control. So they had a stable annular fissure before, but that area of fissure was a location where the patient actually developed a disc herniation. So there have been a number of papers looking at annular fissures. Jeff Ross was actually a fellow under Modick, who actually was the first person to actually come up with what we call Modick changes now, in a paper that he did as a fellow. So annular fissures are generally stable lesions without progression over years, rarely associated with symptoms, and as we said, the term annular tears really should not be used. This is one study. Oh, this is out of Korea. high intensity zone, they felt that if you had it with a protrusion, there was an 87% positive predictive value for concordant discogram. No protrusions, then there was no correlation with pain. But again, discography, I'm not sure really the accuracy of discography. I still do not believe that if you have a high intensity zone or an annular fissure in a protrusion, that is a definite indication for surgery. So now let's talk about degenerative changes in the spine, but why don't we stop here and we'll pick this up on Monday, where we'll talk about how the disc changes with degeneration over time, and we'll then go through the North American Spine Society's classification for how to classify disc herniations. Okay, great.
Yeah.
Have a good evening and have a good weekend, guys and girls.
Thanks, John. And you've got to stop turning off my microphone, John.
Yeah, sure. Long distance, too.
Okay, sorry about that.